I want to talk about vein graft interventions, and I want to focus on distal embolic protection. So an embolic protection device is actually a wire with a filter basket that is advanced through a catheter. The wire is a 0.014-inch wire, and the basket has 110 micrometer holes that allow blood to flow while grabbing onto debris. The basket between the two dots is 1.5 centimeter approximately. It should be positioned in the distal graft, usually close to the anastomosis. And you should have at least a 3 centimeter landing zone between the distal end of your lesion, the green one here, and the anastomosis. And in my opinion, it should be even at least 5 centimeter in order to safely deploy and maneuver that filter basket. This landing zone, that 3 and preferably 5 centimeter, gives you support as you're maneuvering around the lesion, but it also gives you room for error should the basket move during the procedure. If it moves, you don't want it to get stuck in your lesion, or worse, you don't want it to get stuck in your stent once you've stented that lesion. The wire portion of the basket can be in the native vessel. So the distal embolic protection is a basket, and past that basket, there is about 3 centimeter of a free wire. That wire may be in the native vessel, but the basket must be within the graft. Occasionally, you may place the basket in the native vessel only if there is no retrograde filling of the native vessel and if there are no major branches early on in the native vessel. In that case, you can position the basket in the native vessel before a major bifurcation. You don't want to position it past a major bifurcation because otherwise your basket will make emboli preferentially go into some branches while protecting the distal one. And here you see the basket, 1.5 centimeter, and the landing zone, which is at least 3 and preferably 5 centimeters. There are 2 distal embolic protection wires available in the US. One is the Spiderwire, and the other one is the FilterEasy wire. Spiderwire is the one more commonly used and more versatile. It comes in 3 to 7 millimeter sizes, and they are sized 0.1 to 1 millimeter larger than the graft vessel. The profile of the delivery catheter, that green one through which you're delivering the basket, is a 3.2 French, which is larger than the profile of a balloon. Keep that in mind. It's not easy to advance those basket catheters. The profile of the retrieval catheter through which you're pulling that basket is even larger. The profile, the whole of the retrieval catheter is 4.2 to 4.4 French. So you may have issues advancing the retrieval catheter even if you've properly deployed the basket. The profile of the retrieval catheter is actually larger than the profile of modern stent, which is around 3 French. The FilterEasy has the same basket for all vessels, 3.5 to 5.5 millimeters, and it has another basket for smaller vessels, 2.25 to 3.5 millimeters. Those are sizes that are not available with a Spiderwire. The profile of the delivery catheter is almost the same, and the profile of the retrieval catheter is almost the same. Same profile as the Spider catheter. One difference is that the FilterEasy has a straight retrieval catheter. It also has a bent tip retrieval catheter that may be advantageous in difficult cases, as I will describe. Also, ideally, you want to deploy your basket in a straight segment, in a 2 centimeter straight segment. The way you size your spider is that you choose the whole number that is immediately higher than the vessel size. So if you have a vessel size of 3.1 to 4, you choose 4. 4.1 to 5, you choose 5. 5.2, you choose 6. The only exception is if your vessel is a 3 millimeter, you choose a 3 millimeter spider size. And if your vessel is in that 5.5 to 6 range, you can choose 7 millimeter spider. I will explain now how to deploy the spider and filter wire, the technical steps. So I will start with the more important one, which is the spider wire. The first step in deploying spider wire is actually to wire your graft with your wire of choice. You can use a BMW or any workhorse wire, or in difficult cases, you can use a polymer wire like a whisper wire. Then after that, you take the spider wire out of your container, and this is how it comes. It's a basket, and there's a catheter behind it, the green catheter. Afterward, you put the spider wire basket in a bowl of saline, and you pull that wire into the green catheter. You try to squeeze the air bubbles out. That's the point of that. And you may do it a couple of times to squeeze the air bubbles out. And we station that basket in the transparent portion within the green catheter, in the transparent portion behind a white area. Look at it again. So we pull it in the catheter and we position it, as you will see, in that transparent portion here. Then we advance that green catheter over the BMW wire, and the BMW wire will come exactly from here, from that white area, which is actually the monorail portion for the BMW wire. So this is how the spider catheter is. You have BMW white monorail port, behind which you station the collapsed spider basket in the transparent portion. Then behind it, at the back end of the green portion, you'll have the spider wire monorail portion. And after you collapse that spider basket, this is how we advance it over the BMW wire. Here it's being advanced over the BMW wire, and it will come out just in front of that white port. Again, look, it's advanced, and it will come out here, the BMW wire. This is the monorail portion of the BMW wire. And notice we have to bend it a little bit to allow the BMW wire to come out just in front of that white marker area. Then we hold it. Then you see here how the end is. You have the BMW wire, then you have the end of the green catheter, and you have the spider wire monorail portion. The spider basket is positioned here in the transparent portion, and it comes out at the back of the green portion. Again, this shows you the BMW monorail port, which comes out here, the collapsed spider basket, and the spider wire monorail portion coming out at the back of the green catheter. So there are two monorail areas, one for BMW and one for the spider wire, and the collapsed basket is in between. Now you advance the green catheter over the BMW wire, and once you are past the BMW monorail portion, you're advancing, and now once you are over the monorail portion, you hold the BMW wire and you advance both the spider wire and the spider catheter simultaneously. Those are held in sync by your right hand, and they are pushed in sync. And as you are advancing over the BMW wire, at one point you will see the catheter tip at the tip of your guide on fluoro. And when your catheter tip is here, keep in mind that the collapsed basket is way back. You know, when the catheter tip is here, the basket is way back. Catheter tip is here, the spider basket is way back around the star area here. You advance your catheter over the BMW wire all the way to the distal graft, And after you get the catheter tip to the distal graft over the BMW, then you pull the BMW wire, as you see here. Now, after you've pulled the BMW wire, now for the first time, you spread apart the spider wire and the spider catheter. And now you're ready to advance that spider wire that is positioned way back. You're ready to advance it through its own monorail inside the catheter all the way into the distal graft. So see here how we're spreading apart now catheter and wire, and now we're advancing the spider wire in a monorail fashion all the way till it reaches the distal graft. Now you push the spider wire through the catheter all the way until the tip of the spider wire is superimposed with the tip of the catheter while it's still collapsed. Now you are ready to deploy the basket. And the way you do it, you pull the catheter while holding slight forward tension on the spider wire. But you mostly pull the catheter. The idea here is that you want it to deploy in this position without moving forward or backward. You don't want to push it and you don't want to pull it. So basically, you mostly pull on that catheter while keeping a slight forward push tension on the wire. You may even place a torquer here so that you prevent that wire, spider wire, from over advancing. And you put a torquer and you keep a slight forward push on it. And you adjust the pull of one hand with the slight push of the other hand to keep the basket in the exact same place without much movement. And see how it's done here. So we're pulling on the catheter with a slight forward motion on the spider, and you see how it gets open here. And you typically want it in the distal portion of the graft, as I explained. So if that spider basket moves during your procedure, you are still far away from the lesion and from the stent. Now, the wire, spider wire is a 300 centimeter, but you don't need the 300 centimeter. You can work the whole case in a monorail fashion. So you can break it at 180 centimeter. And actually, it is designed to have an area that can be broken at 180 centimeters. This is how you can put a torquer on the wire as you're pulling out the catheter. And normally, you try to pull the catheter while it's coaxial with the wire, so you get better force transmission. So after positioning your wire, now you're ready to take your catheter out. The catheter is a monorail system. You take it out in a monorail fashion, but don't throw it away, because the back end of it, you know, the forward end of it is the delivery, which is green, but the back end of it, that blue portion, is actually the retrieval catheter that you will need to use at the end of the case. The retrieval catheter is a little bigger than the front green portion because you need bigger room to collapse that basket, especially if it has debris. Now, if you have difficulty delivering the spider catheter, especially in patients who have ostial left vein graft disease, your biggest enemy in vein graft intervention is left vein graft, where you get the least support, and left vein graft ostial disease specifically. So in those cases, what you can do, you can double wire up front and advance the spider system over one of the wire while the other wire serves as a body for advancement of the spider. The same idea can be applied if you have already deployed your basket, but you have difficulty delivering the stent over that spider wire. So you can, in that case, add a body wire if you did not have it up front, place a body wire next to the basket. You're not going to be able to advance it past the basket, but you can advance it up until the proximal dot of that basket, which is enough to stabilize the guide, prevent it from kicking out and kicking out the whole system and filter with it. This is an example where you could not deliver the stent over the spider wire, so we added a body wire and we were able here to advance the stent over the spider wire with the support of the body wire. You may consider the use guideliner if the issue is poor guide engagement that is not abutting the aorta and that keeps flying out and is non-selective. But if the issue is difficulty advancing because of that very proximal sharp bend and shepherd crook, body wire is probably better. Guideliner converts a poorly engaged, unstable guide into a large AL with a support from the opposite aorta. Now, how to retrieve the spider wire? So we advance that blue retrieval portion in a monorail fashion. And you can see here be it advance. And you advance it until the tip of that catheter is superimposed on the proximal marker of the filter. Then we pull the spider wire while simultaneously pushing the catheter with the other hand. So we simultaneously pull the spider wire with this hand while pushing the catheter with the other hand until we collapse the basket. We typically push with this hand more than we pull, but the goal is to keep the basket in place, not to move it and create dissections. So you adjust your push and your pull accordingly. You may need to pull more with this hand grabbing the filter if the filter dives in. So you adjust your push and pull accordingly to keep the filter in place. Usually more push with this hand than pull. Now, if the basket has debris or impaired flow, only collapse it partially. So normally you can collapse it fully, pull it all the way till even the distal marker is inside the catheter. But when there is impaired flow or when you see visible debris, then in those cases, you don't need to fully collapse it. Collapse it only until here. So you partially collapse it. You collapse it past that arrow that I show, okay? Because you don't want to spill over those debris. This is what we call partial collapse, full versus partial collapse. If you have difficulty advancing the retrieval catheter, especially across left vein graft shepherd crook with an ostial stent, so if you have difficulty advancing that retrieval catheter, keeping in mind that the retrieval catheter has a larger profile, 4.2 French, and it can get stuck in the stent. As you're trying to advance it, it can abut the struts of the stents, especially on the up hook here. In those cases, one, try to prevent this from happening by sucking the guide in the stent during stent balloon deflation. So as you're deploying the stent balloon, suck the guide in. This is like the inchworming technique we use with guideliner. So that's important to do systematically to prevent this from happening. Two, if even with the guide sucked in inside the stent, you have issues advancing the retrieval catheter, use the body wire technique. If that fails, the third idea is to use an angled retrieval catheter, which is available with the FilterEasy system. This is the angled retrieval catheter, which you can torque around the stent struts or around bends. If you don't have that system in your lab, you can alternatively use an angled 0.035-inch peripheral catheter such as Quick Cross or CXI or Navicross. The problem with those 0.35-inch peripheral catheters is that they are 135 centimeter over the wire system. So in order to use them with a spider, you need to have kept your 300 centimeter spider, not have broken it into 180 centimeter. You could also use them on a 180 centimeter spider wire with a trapper if you have a 7 French guide. They won't fit with a trapper in a 6 French guide. I will move on to explain how to deploy the FilterEasy wire. Unlike the spider wire, the FilterEasy system is not advanced over a workhorse wire. Basically, you pull the basket in the catheter and collapse it at the tip of the catheter, but the distal wire portion remains hanging out of the catheter, and you can shape that wire portion and use it to cross the lesion and wire the lesion. You wire the lesion directly with the filter-easy wire and catheter advanced together. You push the wire and catheter simultaneously. This wire portion is about 3 centimeters, and you shape it in order to wire the lesion. The filter-easy system is easier to prep and understand than Spider, but it is potentially more difficult to deliver if the lesion is difficult to wire, because the Spider allows you to wire the lesion with better wires, workhorse or polymer wires if needed. Here is how we prep it. One, you put it in a bowl of water and you pull the basket in the catheter while leaving the distal few centimeters of the wire to wire the lesion. Then you want to advance that collapsed basket with its wire hanging. You want to advance it through the TUI into the guiding catheter. So you use a peel away a plastic that you put your wire and catheter through it, and you put that through the TUI, and then you push the system. And once your filter wire is around here in the guiding catheter, then you remove that peel away plastic. Then you push the whole catheter wire system with one hand, the right hand, kind of similar to what you do with a Spider catheter wire, except with a Spider wire, it is advanced over a workhorse wire. So like here, you're pushing both the filter wire and catheter together, except unlike with a Spider, you don't have a BMW wire. You're just pushing the other two with one hand. Now, once the wire is beyond the guide in the proximal portion of the graft, then you use a two-handed technique. You start torquing the wire with one hand, with the right hand, while pushing both, holding onto both the wire and the catheter and pushing both with the left hand. So that hand holds both. This hand torques while this hand holds both and push both. It's an in-sync motion of both hands. The key idea is to never push with this hand. If you push with this hand, you will end up deploying the filter prematurely. So you only torque with that hand while holding and pushing with that hand only, exclusively. So you torque while pushing with the other hand, torque and push. And then eventually, when you get your system, both the filter and catheter distally, and you're ready to deploy, then you spread them both apart, and then you're ready to push with this hand while mostly pulling with that hand. Again, this is another illustration here. You torque with this hand, and you can use the torquer provided by the filter-easy catheter system. You torque with this hand while holding and pushing both with that hand, the left hand. Now, once the collapsed filter is in the desired position, then you're ready to deploy it similarly to the Spider basket. You pull the catheter while locking a torquer here and putting a slight push tension on the wire. It is evidently, as you can see, a monorail system as well. The retrieval technique for this is also similar to the retrieval technique for the filter wire, but the filter catheter is a separate catheter available in a straight or bent tip. So here is a more detailed explanation of the technical pitfalls of distal protection. So one, there is only one old trial versus no protection, which excluded ostial disease and distal disease in the distal 3 centimeter of the graft. Two, you have difficult delivery in Shepherd-Crook left vein graft takeoff with poor support. You have difficult delivery in Shepherd-Crook left vein graft with critical ostial or proximal stenosis. And even if you deliver, you may have embolization from a difficult delivery and maneuver by themselves. Another caveat is that in difficult cases, filter may move during difficult manipulation. So even after you deploy the filter or Spider, and I'm using the two-term filter and Spider interchangeably here, even after you deliver that filter may move as you're trying to deploy your stent, especially ostial stent positioning, and as the filter moves, it may create dissections. You may have difficulty advancing the retrieval catheter through an ostial proximal left vein graft stent. Again, the common theme that comes here, left vein graft stent, especially left vein graft with ostial proximal stenosis. This is the biggest enemy for our embolic protection, and this is the case where I'm least likely to use embolic protection because I worry about complications with using it. And filter may get pulled during those difficult manipulation and get stuck in a freshly deployed stent. And keep in mind, in all those difficult steps, the value of body wire. The body wire can be valuable in all the three major steps of vein graft intervention. It can be valuable during initial spider catheter delivery when it's difficult. It can be valuable during stent advancement when it's difficult, and it can be valuable during retrieval catheter advancement. So body wire is very valuable, but keep in mind, do not make a mistake of stenting inadvertently over the body wire. So use the body wire just as a support. You stent over your filter or spider wire, and keep in mind, you need to pull out that body wire as you're deploying your stent, as is the case always when we're using a body wire. So don't make mistake with your body wire, but it's very valuable when used properly. Another idea that, and that may be the main reason why trials excluded ostial vein graft PCI, is that in any ostial vein graft PCI, there is a risk of retrograde embolization in the aorta, even if you don't have distal protection. Even if you don't have distal protection, you can embolize backward and cause a stroke. The risk is potentially worse if you have distal protection here. The filter may cause a sluggish column of blood or aggravate the potential for sluggish column of blood and aggravate the potential for retrograde embolization, particularly when the disease and the heavy atheroma is ostial. And that's why ostial disease was excluded from those trials. Because of those modern observational data, both the ASC and ACC guidelines give embolic protection devices a class 2A in graft intervention, not class 1. So in sum, when to use distal protection? May avoid it in left vein graft with poor guide support, especially left vein graft with tight ostial or proximal stenosis or stenosis at the bend. To use filter or spider, consider upfront body wire and consider spider, not filter in those cases. Likely avoid in very ostial disease within 1 centimeter of the ostium as per the landmark SAFER and FIRE trials because of all the ideas I described earlier of support and deliverability, but also because of the risk of retrograde embolization, particularly when that full basket creates a stagnant column of atheroma all the way to the ostium. Strongly consider using it in all right vein graft, especially right vein graft over 3 years old, which is when you start getting a lot of the heavy atheromatous debris in the graft. Strongly consider it if you have good guide support, right or left vein graft, and you have a bulky degenerated vein graft. Strongly consider it when you have good guide support and lung disease, which is by definition more risk of atheromatous embolization. Also strongly consider it when you have good guide support and you have visible thrombus or acute coronary syndrome. No need to use it in stent restenosis because stent restenosis tend to be a fibrotic process, not a friable atheromatous debris type of process. Another troubleshooting idea, what to do if the basket is full of debris and the flow is impaired. If the flow is mildly impaired and you've already stented, just remove the filter and only partially collapse it with your retrieval catheter during retrieval. Now, if the flow is severely impaired, you have a large thrombus or a large piece of atheroma blocked at the filter with a stagnant column of blood and no flow, removing the filter here may cause distal emboli, which defies the purpose, or worse, it may cause retrograde embolization into the aorta and the brain during the retrieval process. So in that case, you should consider thrombectomy. And we consider in those cases penumbra, which is the best thrombectomy catheter, the most forceful suction catheter. So we advance the penumbra monorail thrombectomy catheter, and we try to suck as much atheroma and debris in that stagnant column of blood. Consider placing a body wire for support as you're advancing your thrombectomy catheter. Also, the body wire allows you to maintain wire access after removing the filter. Now, keep in mind that the thrombectomy catheter, you're not going to be able to advance it beyond that proximal marker, that catheter stop of the spider or filter wire. So you'll be able to advance it until here, but that's enough because the strong suction of the thrombectomy catheter can suck more distally debris that are inside the basket. Now, if the slow flow persists, consider aspirating through a distally advanced guideliner. So advance a guideliner distally over your spider wire, and you try to aspirate through the guideliner. This is an illustration. You can advance the guideliner distally over the spider wire, and you aspirate through your TUI. You open that area here and you suck vigorously. The sucking through the guide will in fact be in line sucking through the guideliner. So you suck from here as the guideliner is distally, and you will actually be sucking through the guideliner into the guide, into that TUI. Now, if you're established flow, great. If you're not done with your procedure, you can stent, then eventually partially collapse the filter and remove it. If the flow remains impaired after doing all this, then you just have to remove the filter at this point, partially collapse it and remove it. And frequently, after having done all this, then partially collapsing the filter and removing it, your flow will be reestablished. If you're not done with your procedure, if you need to do more maneuver, like you haven't stented yet, or you need to put another stent, you may consider deploying another spider in place. But keep in mind, at this point, after so much emboli, you may also want to reduce the number of your steps and may just go straight with the stenting at this point. Other ideas: there is no benefit of 2B3A inhibitor in vein graft PCI. This was shown even in the era where 2B3A were widely beneficial across a wide range of lesions. Meta-analysis has not shown a benefit of 2B3A in vein graft intervention specifically, simply because vein graft debris are atheroma, are pieces of atheroma, not so much or less so than thrombi. However, you may consider local 2B3A through a distal catheter if you have no reflow before and or after filter removal, especially if when you do thrombectomy in those sluggish flow cases, the thrombectomy shows you a lot of red material, which are red thrombi. Also, you should consider distal vasodilators delivered distally through a dual lumen catheter in those slow flow cases. So those are other strategies to reduce distal embolization. They are useful in all cases, but they are particularly useful when you are trying to avoid using embolic protection in difficult cases, left vein graft, proximal disease, or you don't have good landing zone. So you can do direct stenting, no pre-dilatation and no post-dilatation, but this is only applicable if your stenosis is not critical and you have good guide support. It's probably not applicable for the left proximal Shepherd-Crook stenosis. Another very important strategy is slight stent undersizing, less than 0.9 to 1 reference lumen, maximal 1 to 1. Each one of those two reduces peri-procedural MI by 50% based on those studies. Also, pre-treatment with vasodilators, whether verapamil, nicardipine, nipride, or adenosine. Each one of those in separate studies has shown a reduction of no reflow by anywhere from 75 to 90% reduction. So there is a dramatic reduction of no reflow with those medications, which you should use pre and post stenting. So use them preemptively before balloon and stent, then you use them after. And that's how I typically use them. All of them, the dosing is about 100 to 200 microgram. Verapamil is a little more than that. You can do with verapamil 200 to 500 microgram.